In this video, we discuss integrative cancer treatments in the perioperative surgical window. As always, these ideas are discussed in more depth in the book Cancer Self-Defense 101. Quick tips to help you survive. All citations for studies quoted in this video can be found in the book's bibliography at cancerselfdefense101.com. This video is intended as information, not medical advice. It is not intended to treat, diagnose, or cure any disease. Any medical advice should come from an appropriately credentialed medical professional familiar with your unique circumstances. Surgery is one of the oldest methods to treat cancer and is typically a very good idea, particularly with early-stage cancer, if possible. Despite surgery typically being a good idea, it can also produce an environment in the body that makes cancer more likely to grow and metastasize. Metastases are typically more fatal than the primary tumor. Whether or not surgery is suitable for you is a conversation for you and your medical professional. Our purpose in this video is to inform you about different aspects and types of surgery and ablation, and to discuss how to make surgery more effective should you choose to go through with it. The systemic effects of surgery. The biological effects of surgery are numerous. Obviously, there is the upside that the tumor is removed and it can no longer emit its immunosuppressive molecules. See our blood filtration video. However, there are an enormous number of biological changes that arise out of surgical trauma. They can be summarized as immune suppression lasting anywhere from a few days to 6 months, increased local and systemic inflammation with C-reactive protein levels, a biomarker of inflammation, increasing over 3,000% in the first few days after surgery, increased cancer cell adhesion, an increased number of circulating tumor cells that typically lasts for at least 14 days. When taken together, the post-surgery environment is the perfect breeding ground for metastases. Animal studies have shown that surgery can make metastases more than 3 times more likely. Surgical wounds, either 1 time or 2 times, make metastases approximately 3 times more likely after mice were injected with aggressive breast cancer cells. In the same experiment, in mice without a surgical wound, only 10% of tumors persisted, whereas in mice with a surgical wound, more than 60% of tumors persisted. The tumors in the wounded mice were also at least twice as large as in the mice without a surgical wound. Human studies have shown similar results with surgery, increasing the aggressiveness of cancer cells, while simultaneously decreasing the percentage of cancer cells in apoptosis, cell death. The authors of one review on the effects of surgical treatment of colon cancer concluded, "This finding strongly supports that surgery alters the natural course of the disease by elongating life expectancy in the greater part of the patient population, but also by simultaneously shortening survival in a smaller subset of patients. Thus, both experimental and clinical evidence support that surgery, although greatly reducing tumor mass and potentially curative, paradoxically can also augment metastasis development. Surgeries with higher APGAR scores have been associated with worse overall survival in cancer patients. APGAR score is a predictor of post-surgical complications. It is obtained by measuring the estimated blood loss, lowest mean arterial pressure, and lowest heart rate during the operation. Surprisingly, it is not clear that laparoscopic, minimally invasive surgery is any better than open surgery at improving survival rates in cancer patients, although there is evidence that laparoscopic surgery can produce fewer post-operative complications and shorter hospital stays. The biopsy. Some kind of biopsy is necessary. Hopefully we'll get to the point where liquid biopsies, a diagnosis drawn from blood, can supplant surgical biopsies. Liquid biopsies are available now and may be an option for you with the recommendation of your oncologist. Although minor, a needle biopsy is a form of mini-surgery and can have some of the negative impact of surgery. Additionally, a biopsy can cause seeding, which is when tumor cells get on the instrument used to do the biopsy, then dislodge and eventually create a tumor along the tract that is used to pull the instrument out. Seeding is a relatively rare phenomenon. It occurs in less than 1% of cases, although seeding risk increases with advanced cancer and brain tumors. Here is an MRI from a glioblastoma patient. The red arrow shows seeding along the biopsy track. One retrospective study of glioblastoma patients found that a biopsy caused tumors to grow faster, and that the application of dexamethasone counteracted that. Dexamethasone is a corticosteroid commonly used with any kind of cerebral malignancy to reduce swelling. Incidentally, there has not been shown to be a survival benefit to either an excisional biopsy, where the whole tumor is cut out, or an incisional biopsy, where a needle enters the tumor. They have pretty much equal results. Vacuum-assisted biopsy devices can improve outcomes, but they are still not widespread. Improving surgical outcomes. Decreasing the systemic adverse effects of surgery is a promising way to reduce the potential of metastases. One of the systemic effects of surgery is an increase in cancer cell adhesion. One mechanism for this is the upregulation of the COX-2 enzyme. Fortunately, NSAIDs inhibit the COX-2 enzymes. A meta-analysis of 19 studies examining the use of NSAIDs in the perioperative window, roughly a week before surgery to 2 weeks after, found that NSAID use improved overall survival 22%. NSAID use in the perioperative window decreased disease recurrence by a dramatic 42% in breast cancer patients and 31% in lung cancer patients. Many surgeons will advise against preoperative NSAIDs use due to the increased risk of bleeding during surgery. This was not borne out in the meta-analysis, but taking NSAIDs post-operatively has also shown substantial benefits. The NSAID with the strongest effect seems to be ketorolac, and after that diclofenac, but even aspirin and ibuprofen have shown benefits. The non-selective beta blocker propranolol works against a variety of aspects of the post-operative metastatic cascade. It reduces inhibitory immune cells, known as Tregs, and improves the numbers of cancer-fighting CD4 immune cells post-surgery. A combination of propranolol and the NSAID etodolac were found decrease 3-year recurrence rates after colon cancer surgery from 33% to 13% in a placebo-controlled human trial. A retrospective analysis of 43 breast cancer patients who underwent surgery found that a non-selective beta blocker, for example propranolol, use was associated with a 57% reduced risk of metastases. Another retrospective analysis of 209 prostate cancer patients undergoing surgery found that propranolol was associated with a 36% reduction in cancer recurrence. Propranolol, 40 milligrams, used 2 days before and 3 days after surgery also reduced CA-125, a biomarker of cancer progression, 39% more than placebo after ovarian cancer surgery. Propranolol concurrent with standard of care, including surgery, increased median overall survival to 36 months from a historical average of 12 in a group of angiosarcoma patients. Propranolol has also been shown to reduce complications after surgery. E-selectin is a molecule on the surface of blood vessels that circulating cancer cells adhere to. After surgery, E-selectin expression more than doubles, thereby increasing the likelihood of metastases. A randomized controlled trial showed that cimetidine, sold commercially as Tagamet, significantly reduced the expression of E-selectin. However, levels quickly returned to baseline after cessation. Human trials have also shown that cimetidine increases the penetration of immune cells into the tumor, and cimetidine use during the perioperative window increases natural killer cells by more than a third compared to placebo. These qualities, among others, have made cimetidine a valuable adjuvant during cancer surgery. A meta-analysis of 5 trials involving 421 patients revealed that cimetidine, given concurrent with surgery, improved survival by an impressive 47%. Galectin-3 is a cellular adhesion molecule that is elevated in every cancer and associated with a worsened prognosis, including increased chances of metastases. Galectin-3 increases by roughly 50% immediately following surgery. Additionally, the binding of galectin-3 to blood vessel walls, a harbinger of metastases, increased by 250% in a preclinical trial mimicking surgical conditions. So, not only are blood levels of galectin-3 higher after surgery, it is more likely to adhere to blood vessel walls and initiate metastases after surgery as well. Higher levels of galectin-3 have also been associated with increased surgical complications. A potent galectin-3 inhibitor that has also shown positive outcomes against cancer in randomized controlled trials is the dietary supplement modified citrus pectin. The Pectisol brand is most widely studied in clinical trials. PDE5 inhibitors, such as Viagra and Cialis, improve immune function and reduce blood vessel stiffness, thereby reducing the chances of cellular adhesion. A retrospective analysis of 1,136 male colorectal cancer patients revealed that those who used PDE5 inhibitors during surgery had a 28% lower mortality rate than with their counterparts who did not use anti-PDE5. PDE5 administration was also found to preserve natural killer cell cytotoxicity in colorectal cancer patients undergoing surgery. A preoperative PDE5 inhibitor was also found to reduce Tregs, inhibitory immune cells, after surgery in head and neck cancer patients. Statins improve cardiovascular system function and exert anti-inflammatory effects. Both factors contribute to statin use improving surgical outcomes. One retrospective analysis of 6,494 colon cancer patients who used statins in the perioperative window found that statins led to an incredible 88% reduction in 90-day all-cause mortality. An 87% reduction in 90-day all-cause mortality was found in a retrospective analysis of 3,019 rectal cancer patients who used statins during the perioperative window. Another retrospective analysis of 5,896 colon cancer patients who underwent surgery found that statin use conferred a 24% cancer-specific survival advantage compared to non-use. Statin use has been found to be beneficial during many surgery types. For instance, a meta-analysis involving 4,707 patients who did not have cancer found that statin use led to significant decreases in post-operative stroke and heart attack in non-cardiac surgery. Statin use also showed decreased complications in a randomized controlled study of major pulmonary resection. Withholding statins during the perioperative window was also associated with increased complications compared to continued use in head and neck cancer surgery. Atorvastatin is the most widely used statin for cancer patients without brain metastases, while simvastatin may be most promising for cancer patients with brain metastases. Some of the most powerful, easily accessible, and well-tolerated immune modulators are medicinal mushrooms. Unsurprisingly, they also show a benefit when administered in the perioperative window. One meta-analysis of 8 controlled trials involving 8,009 gastric cancer patients who had undergone surgery found that PSK, a proprietary turkey tail mushroom extract, current with standard therapies, led to a 12% survival advantage over controls. The 3 highest quality of these 8 studies pointed to a 22% survival advantage. Avamar, a fermented wheat germ extract dietary supplement, has also shown powerful immune modulation properties and similarly improvements in the outcome of surgery. 66 colorectal cancer patients underwent surgery, concurrent with standard of care treatments, and 9 grams of Avamar daily for 6 months, while 104 colorectal cancer patients underwent surgery with standard of care alone. In the Avamar group, 7.6% of patients developed new metastases, while in the control group, 17.3% did. Over the nearly 3-year observational period of the study, the mortality rate of the Avamar group was 12.1%, while in the control group it was 31.7%. Another controlled trial examined the use of Avamar concurrent with surgery and standard of care for oral squamous cell carcinoma. The Avamar group had an 85% lower chance of disease progression over 12 months than the control group. Other treatments found to improve surgical outcomes include mistletoe, extract, chemotherapy, radiation, immune checkpoint inhibitors, whole body hypothermia, thymosin, alpha-azoxima, bromide cancer, self-defense. 101 provides all citations supporting these claims. Perioperative medicine management is probably the least studied area in all of oncology. A survey examined the responses of 75% of all anesthesiology program directors in the United States regarding chronic medicine used during surgery. Answers varied widely on continued steroid use, aspirin ingestion, amount of time the blood thinner warfarin should be discontinued before surgery, and more. The answers to some questions were 50-50, meaning there is no standardized guidance regarding chronic medication use during surgery. This is true regarding the continued use of oncology drugs as well. For more information, please see the book Cancer Self-Defense 101, Quick Tips to Help You Survive.